My pleasure, and thanks to everyone out there who's joining us tonight. I know you all probably worked all day today, and now you're spending a short 30 minutes with me learning a little bit about digital dentistry, in particular, the digital patient. So let's get rolling. So a little bit about me. I do work in a private practice with some really talented and somewhat well-known dentists. I guess if you can be well-known in the dental world, these guys are. But so what you're going to kind of hear about today is how we do things in our practice. And just to tell you a little bit about the practice, we are a general dentistry practice, but we really are known for doing a lot of cosmetics. We're known for doing comprehensive dentistry, and we're known for doing kind of tougher cases with TMD and airway. And extremely lucky to work with these dentists, but really the stars of the show, and especially when it comes to implementing technology day to day in the practice, is our team. Our team has come a long way as far as their comfort level with what I'm going to speak on tonight, and they are the ones that drive the implementation of this technology. And to their credit, they bought into this from day one. So, when you implement or when you purchase technology, obviously your team has to be part of that process, right? Giving them training, making sure they're on board, making sure they see the value of the technology. And so that's part of what I'm going to talk about today, and how we really bring value out of this technology in a way that you may not necessarily think of right off the bat. People talk about return on investment and things that you can see a linear correlation. I bought X piece of technology and it makes me Y amount of money. Well, there are a lot of intangibles within that people don't necessarily consider. So that's a big part of what I'm going to talk about today. And it's within the scope of this digital patient. I love AI images. This was an image that I created on one of the artificial intelligence image sites. But I was thinking of the digital patient. This is the image that was spit out, which I think is kind of cool and at the same time quite terrifying. So anytime I talk about digital technology, I try to speak in a way that dentists understand, right? We understand two arches, the maxillary and the mandibular arch. So when we're thinking of the two arches of dental technology, the maxillary arch in my mind is data capture, right? We bring a patient in, they're new to our practice. We need to capture data on them so that we can diagnose, treatment plan, and then implement that treatment. And that includes things like photography, both intraoral and extraoral, CBCT, cone beam CT, which is essentially a 3D X-ray, and then intraoral scanning. And all these things kind of fit within the capture, along with 2D radiology and face scanning. If you're really into technology, face scanning is still kind of a niche technology, but that is part of the capture arch as well. And then the second arch, the mandibular arch, is create. And that is taking all that data that you captured and then making something out of it. So either milling or 3D printing or something where you're actually creating something physical for that patient. And then the kind of articulation that brings these two arches together is digital design. And digital design is a little bit of a sticky point for a lot of dentists who are trying to implement technology because maybe they don't want to have to mess with the digital design. But the reality is there's a lot of opportunities to outsource this at a really reasonable price, or you can purchase software or use free software to do the digital design yourself. So there's a lot of different options for digital design. Once again, I will go more in depth on that in Las Vegas here in about a month. And then the virtual patient creation is what we do in our practice with every new patient. And it's basically capturing all this data, right? We take an intraoral scan, we take a cone beam, 2D radiology, intraoral photos, and extraoral photos. And the idea of this is that one, it gives us all the information we could possibly need to adequately treatment plan the patient for all sorts of different things. The other thing is it gives us the ability to study the patient or treatment plan the patient when they're not in the office, right? And so we'll go a little bit more in depth on this, but I always like to start with intraoral scanning because this is kind of the technology I think that most people have implemented in their practice already. I think the adoption rate of intraoral scanning is now over 50%, which is fantastic. But the idea of intraoral scanning is you're creating a three-dimensional file essentially of a patient's dentition. So it's in the old days when we used to pour up stone models, we used to have to keep those around. We no longer have to do that. We have data that we can capture where we can store very easily of a patient's dentition. And I like to essentially explain intraoral scanning in this way. When you're scanning a patient, the very first tooth that you start scanning is like the foundation of your three-dimensional model. And every picture that that intraoral scanner takes has to build off of that foundation. And that is the way that scanners work. They essentially put new data on top of old data, but there has to be overlap between those two pieces of data in order for that model to be built accurately. The good news is now there are algorithms working in these intraoral scanners behind the scenes that are able to do this really accurately, regardless of whether you're a new intraoral scanner or someone like me who's been doing it for 15 years. The algorithms really work well to be able to create an accurate model regardless of your level of experience. But in a case like this, where we're trying to build this photo, this first image, right, the first scan of the first tooth that we image is the foundation, and off of that we overlap data until we've captured everything that we need to capture in order to create the model, whether it be a quadrant, whether it be a full arch, whether it be two arches and articulation. We can do all of that with these intraoral scanners. So it's a really powerful tool. And most people think of intraoral scanners as just something that essentially they can use to capture a crown and bridge impression. And you absolutely can do that. But I want to talk a little bit as we go through this about the value of some of the other things that you can realize by having this data on hand all the time. The single, I think, biggest benefit from going from physical to digital is the fact that we no longer have to store models like we used to in, I say the old days. I've been practicing dentistry for 21 years now. So I remember my locker when I was in dental school was full of physical models for all my patients, right? And I've been in private practice dental offices that still store these models, particularly ortho offices that still store these models. Of course, my models never looked this good, but you get the idea. Now we put them either in the cloud, you can put them on a hard drive or a server. It's much easier to store this data and not have this massive storage issue that we used to have. What is the benefit of this? Well, the benefit of this is if we have this information on a patient and a patient calls us Monday morning and tells us they took a header off of their electric scooter. By the way, electric scooters have been great for business for dentists. As you well know, you've probably experienced this yourself, unfortunately. But if you take a header off of your electric scooter and you've broken some teeth, the nice thing about having this data already is I can 3D print this model and I can make a lingual putty that I can then use to do direct composites that same visit to put this patient back together again. So, no, these might not be the final restorations that we need for this situation, but the reality is I have put that patient back together. Now she doesn't have to worry about her teeth. She can worry about the other issues that she's having as a result of this accident. And she can move on and begin to heal. And so these sorts of things are really convenient, not only for the patient, but it helps as a dentist to know that whatever walks into the office, because of the technology that I have and the fact that we've captured that data on the patient already, I can manage just about anything that walks through that door. So just a little bit on intraoral scanning. Like I said, it is an incredibly valuable thing. As we go through the rest of this presentation, I'll talk a little bit more about how we use those intraoral scans, but every single new patient gets an intraoral scan, and I always have a reason to use that scan, no matter what we're doing with the patient. So the second thing that I'm going to talk about is CBCT, which is essentially a three-dimensional X-ray. And the nice thing about this is it gives us a tremendous amount of data, whereas before with 2D radiology, there were always issues. I'll talk about that a little bit. Always issues with superimposition of anatomy over the teeth that sometimes made it hard to diagnose stuff. But just to give you an idea of what the view looks like in a CBCT reader, this is essentially what it looks like. And this is my These are my teeth. Speaking of taking headers, I got elbowed in when I was in grade school playing basketball, and I had to get a root canal on number 8. And so what you're seeing is the root canal that I got on that tooth. CBCT allows me to view that from all different angles just to make sure that everything is still in good shape. And that's not the only thing we can do, but that's actually really important, is that it gives us a lot more information to be able to accurately diagnose, once again, whatever comes into the office. And there's been some studies on this that have compared what you can diagnose off of a 2D X-ray versus what you can diagnose off a CBCT. And what they found is that if you see something on a 2D X-ray, you might think, that looks a little bit suspicious. But when you see it on a CBCT, there is no doubt that there is an issue, right? A periapical radiolucency that we can easily read. And I've found that to be the case time and time again. My assistants know now that when a patient comes in and they're having a problem with a maxillary molar, because we know we've got the sinus in position up there, that's sometimes difficult to diagnose in 2D, to always take a tooth CBCT image, because it's every time we are a little bit questionable on the 2D, it's very easy to diagnose. And what this study found is that when you, an intraoral PA, you only get clear identification of a lesion about 25% of the time, whereas with the CBCT, you get, it reveals that lesion every single time. So I won't go into the details of why that is. Obviously, being able to see it from a few different angles really, really helps. You get rid of that superimposition. But the reality is you're just able to diagnose more. And if you're able to diagnose more, you're treating more. Not only that, but having a patient come into your office and taking a 2D X-ray, this always used to be really unsatisfying for me when they were having pain, but I didn't know exactly what was going on. I couldn't accurately diagnose. And I find that that's not the case anymore with a cone beam. The other thing that's really great is it's become the standard of care for not for doing root canals for sure, but also for placing implants. And the idea, the workflow in a nutshell for placing implants using a CBCT is not just find the bone and put the implant in, it's to actually work backwards. And this is a prosthetically driven workflow now, where we actually start by taking our intraoral scan and taking our cone beam CT, and we can merge these two things together using common data points. It's essentially as easy as putting dots on cusp tips to line everything up. Once we have the intraoral scan and the CBCT combined, we can then add a waxed up tooth. So essentially we haven't even started thinking about the implant. What we're doing now is we're putting the final design and we're merging that on our intraoral scan and our CBCT, because I want to know exactly where that tooth should be. We're lining up the CEJ. We're basically essentially planning the final restoration before we've even planned the implant. And what that does is it helps us to really accurately figure out what depth this implant needs to be at, where the ideal position would be if we want to have this be screw retained versus cement retained. And I think most of us prefer screw retained restorations. And then, and only then, do we actually virtually place the implant where the bone is available. So we've done all this to create a surgical guide that we can then put in the patient's mouth and use to place the implant really, really accurately. And this has become the standard of care for placing implants. The other thing that I've learned about in the past few years that endodontists are starting to do is to do guided root canal access holes, right? We know that if we can be more conservative on our root canal accesses and reduce the amount of healthy tooth structure we remove, that can be beneficial for the long-term health of that tooth. So using CBCT is really becoming quickly the standard of care. And once again, it just helps you diagnose more. Here's an instance. This was an incidental finding. This is part of our virtual patient. So we're taking these on every new patient. We do it at a really reduced fee because, once again, it just helps us to diagnose better. And when we are able to diagnose better, we're able to treat better. So this was the patient who came in, and obviously we've got these 4 views that we can look at. But if we break it down for each view, when you're looking at it from this angle, we're essentially looking at the front of the patient's face, and we're always lking for symmetries when we're reading a CT like this. And what you're seeing are the maxillary sinuses, and that right maxillary sinus. So it's opposite of the right left that as you and I are viewing it. So that right maxillary sinus is within normal limits. It's filled with air, so it appears black on the CBCT. You can see that left one is quite a bit different, right? It's full of something. Well, what is that something? Well, let's look at some of these other pans. This is looking at it now from the sagittal view. And as we look at it, maybe you can start to discern there might be an issue with one of those maxillary teeth. In this particular slice, it's a little hard to see, but what could be causing that fogginess of that maxillary sinus? Well, let's keep looking at the different viewpoints. Now, as we look at this, you can start to see maybe a little bit of bony change around the roots of those teeth. That's interesting. And that's right in the area where the sinus might be affected by this. And then as we go to what I call the Halloween view, and we can see now there's a clear fenestration of that uh, um, adjacent to tooth number 14, and it's pretty clear that we've got a periapical radiolucency. So this helps us to more adequately diagnose. This is something called odontogenic sinusitis, where a tooth that has gone bad and essentially created an abscess that is now draining into that maxillary sinus. And this can potentially be a serious condition. So being able to diagnose this is really, really helpful. So now we can not only get the tooth addressed, but also refer this patient to an ENT to have the sinusitis treated as well. It's really, really important to get that adequate diagnosis. So I love CBCT. I didn't, I was when we first got it in the practice, I was kind of like, that's interesting and all, but I don't know that I realized just how much value that it would bring to our practice. The next thing is dental photography, and photography, both intraoral and extraoral, for me is the best teaching tool that we have in the practice. And I am a huge, I'm an educator. You saw that I teach at a dental school, and I have for the last almost 15 years. I love teaching students. I love teaching patients as well. And so to have a photograph on the screen of a patient's tooth is really, really helpful for me to be able to educate them on what is happening in their mouth. So photography is a big part of what we do. We have basically two sets of photos that we take. We have new patient photos, and then we offer a cosmetic consult as well, where patients will come in for a specific, problem. Maybe they're interested, like this young lady, and who has a class 4 that she's not happy with. So it's a really simple photo workflow. Our team is responsible for creating these, and they are very good at their job. We've trained them to be very good at their job. It's hard for me to diagnose and teach if I don't have good photos that I can show the patient. Once again, a part of this is we're creating a first impression for these patients. I'm in Charleston, South Carolina. There are a ton of dentists in Charleston, South Carolina, because it's a nice place to live. We have a dental school here. People don't really leave, right? So how am I going to set myself apart from the dentist down the street or the 10 dentists right down the street? These are the little things that we can do to help build our practice. So once again, these are our new patient photos. I can put these up on the screen. We can talk about what the patient doesn't like. And clearly this is a pretty obvious one, obviously. We've got a class 4 here that looks pretty bad. The other thing is, for when it comes time to execute this treatment, right? How am I going to mimic what the patient's natural teeth look like? When I look through my loops at this tooth, I don't necessarily appreciate all the details in that incisal edge. But with a photograph that I can blow up on the screen, now I can exactly see, right, that we've got incisal translucency. I can see where those mamelons are. I can start to plan this case in my head. I can think about what the materials are going to be that I'm going to need to execute this case. I actually replaced this class 4 just today, and I'm not going to show you that because I don't have time to. Maybe I'll show you in Vegas. So if you're in Vegas, we'll complete the loop on this case. But it turned out really well. But I couldn't do that if I didn't have photography to be able to mimic what the patient has in her mouth. And look at the texture on that tooth. If I make number 9 perfectly smooth, there's going to be a little bit of a texture mismatch there. You have to be able to see the details in the teeth to be able to replicate it. And that's a big I think one of the things that's really helped make me good at doing anterior composites and really aesthetic dentistry in general. So it's the same thing. We 3D print that model, we create that lingual putty, right? We can execute that case. We'll talk more about 3D printing in Las Vegas. I'm a huge fan of 3D printing. Most of what I 3D print are models for this exact thing. We'll talk about that. And then a case like Dom's. So photography is super important. Dom's a local dentist who came to us because he wanted to fill those gaps in his front teeth before he got married. And so once again, we always start with photography. When I was younger, I used those glasses. Those glasses just kind of help line the patient's head up. And I'll show you why that can be important, especially if you're new to photography. So as we look at Dom and we draw some lines down his face, you can see his midline is pretty good, right? As far as lining up his interpupillary line with the middle of his face. But as we zoom in, what do you notice? Do you notice that his maxillary arch, in particular, the laterals and the centrals, kind of have a sway to the left, right? We put those lines back on. Can you see, right, how those teeth just have a little bit of a cant to them? Would your lab technician, if you sent impressions, right, of this patient to the lab without a photograph, and you asked them to make veneers for you, they would not know that those teeth are canted. They would just right off the bat, essentially, just assume that that midline was on, right? And everything that you got back from them would then recreate that cant. So photography is a great tool for lab communication, really helps to make sure that the result that you get back from the lab is on. Now, I was able to show this to Dom. He's a dentist, right? He knows all about this stuff. And we talked about the fact that sometimes that interpupillary line is not necessarily representative of how his natural head position might be, right? Everybody's a little bit different. So if we redraw those lines now and we instead look at the tip of the canine, can you see, right, that one eye falls below the other? So this is how the lab would have seen this case, and this is why they would build this back with a cant. So instead, what I can do is I can take this photo, I can merge it with my intraoral scan. Once again, that intraoral scan is a vital piece of data. And in a design software, I can essentially create a wax up for Dom. We can show him what his prototypes will look like once we implement this case. And you can see a before and after. This is a little not quite so photorealistic as we might like to show a patient, but Dom absolutely loves to see this sort of thing because once again, he's a dentist, right? And without photography, you can't necessarily make sure that you're going to get a solid midline on a patient without a cant, especially someone who starts treatment with a cant already in place. So that's one of the benefits that we really realize with extraoral photography. And then intraoral photography, once again, one of the things that I absolutely love is sitting down with a patient to show them their own teeth. I think it's a really important part. Most patients have never seen their own teeth, and sometimes they're grossed out by this. I don't really care, right? If you have an issue on a tooth, I'm going to show it to you. Because remember, every new patient is brand new to us. They don't know us. It's for me, it's about building trust. So when a patient like this, when I tell them, hey, you've got a cracked tooth, you've broken out a filling, you need an onlay, right? I can show them exactly what I'm talking about on that photo. Same thing with this. Most patients, they don't necessarily know what a healthy tooth looks like, but you can look at this tooth as a layperson and tell that there's something going on. And chances are good they understand that when you tell them this tooth needs treatment. And then a case like this, where we see a lot of patients in the course of 6 months, and maybe we'll put a watch on a tooth and we'll say, oh, Mrs. Jones, we're going to watch this. We'll take a look at it again in 6 months and we'll see how it looks then. Well, I don't remember from 6 months to 6 months what a tooth looks like. So what do? Well, we take an intraoral photo of it. My hygienists are constantly snapping these on areas that look a little sketchy, so that we can monitor them and see if things change. So this is an intraoral photo we took 16 months ago on a patient. And this was how it looked when they came in a couple weeks ago, right? Things have changed. Now we can say, hey, Mr. Jones, this is how it looked 16 months ago. This is how it looks now. That cavity is starting to get a little bit bigger. It's time to do some work. And patients understand that. And it's not a matter of trust anymore because you're showing it to them. It's right there on the screen. They can see that there's a problem there. So it ends up being really helpful for me. John Coyce says that you should make the data the hatchet man. It feels bad as a dentist to tell a patient that they need a crown. You're going to have to spend all this money on this tooth. It's not me that's telling you that. I'm showing you this picture. It's the data, right, that ends up being the hatchet man. So I love how John put that. It's really, really cool. So that's all that I have for tonight. Unfortunately, I only had about a half hour, but I do want to take some questions if you all have any. Because yeah, you got me here for another few minutes, so we might as well chat a little bit. While we're going to do that, I'm going to put this QR code back up just in case you are interested in coming out to Vegas. By the way, I hear I've never been to Resorts World, but I hear really good things from my friends who frequent Vegas, and so I'm excited to check out that spot.
Wow, thank you so much, Dr. Manito. That was awesome. And thank you for walking us through how you basically use these tools and build a better practice and trust with your patients. So, really wonderful to hear you. And like Dr. Manito said, we have them for a few more minutes. So, if you have any questions, we'd love to invite you. We'd love if you'd add them, just drop them in the Q&A chat box. We'd love to invite you to add them in as well. Yeah, in the meantime,
Unless I did such a
oh,
good job explaining things
answering, that's
that there
possible
are no
too.
questions,
That's,
right? It's probably.
well, it is 8:29. I guess we have another minute or so. Um,
So I will say this about I'll be at Thrive Live obviously, but there's also a lot of speakers that I'm interested in. I take a lot of CE because I really like to learn, and the list of speakers at this event is phenomenal. I mean, there are some really really great speakers that Henry Schein has put together for this event. So obviously Vegas has its own appeal for some people. This come for the CE, stay for the craps maybe. But it's going to be a really good meeting. And then they have some great entertainment as well. I forget who the headliner is, but they usually have a comedian or who comes out and entertains everybody. So it's a good time. It's a good CE. It's a really great event. They do a good job putting it together.
Thanks, Dr. Manito, for sharing what that's like. Yes, we'd love to have folks out there register and attend. And like you said, you're an example of someone who gave great content today and will be speaking and will be able to give a more in-depth look at how you're using your tools that are really revolutionizing practices and the patient experience as well. Well, yeah, we don't have any questions at this time. So I just I
All
want to
right.
thank you again, Dr. Manito. That was awesome. And yes, like Dr. Manito said, it's April 30th to May 3rd at Resorts World Las Vegas. You've got that coupon now for anyone who attended tonight. And once again, Dr. Manito, thank you for a wonderful presentation. And we thank all of you guys for joining us.